Now we will continue with debate 4, towards other ways of practicing. And here we'll go back to young people and industrialization. So Cécile Montet, François Pellen, Thomas Riquier, and Camille Tricard, and the moderator, Michael Benzaki. So please come and have a seat around the table. Thank you, Guy. Good afternoon, everyone. Thank you again for the team here giving us the possibility to discuss this very essential question, which is new ways of practicing. It's interesting because we've just heard a roundtable about the industrialization of the healthcare system. I think this was purposeful on your part, but it's quite logical. What's quite amusing in the new types of practices, whether it's a doctor without patients or a public healthcare doctor, it's a public healthcare doctor who's moderating this debate on new ways of practicing. So I think that's a good choice. So we now have 5 years, have been given 5 years to assess, and we will talk about people with a big capital P. We'll talk about structures, and which are the corollary of these new types of practices, with simple questions. Will new technologies revolutionize the ways we practice? Are we all going to be treated in these booths without any contact with the doctor that we were hearing about earlier? Or will we free up the doctors from their bureaucratic administration? Let me just make one comment on that film. It was a male doctor. So I think the generations are changing, and we no longer have the same configuration in the doctor's profession this year. So will these new modes of exercise or practice only be embraced by young people? So we have a young roundtable here, young and dynamic. And before we start the debate, let me remind you that we have less than 30 minutes. So if you could give short answers and no hollow rhetoric, please. We're just among friends. Nobody's listening, and it's after lunch, so some of them may be snoozing. So just one question for Cécile to start. Cécile Montet, you're a general practitioner. You are a fan of new technologies, and you founded the Hippocrates community online. Are these new technologies going to revolutionize the way we practice on a day-to-day basis? Are they really revolutionizing our usage? Well, the answer is yes, but we shouldn't confuse things. They will not replace healthcare professionals. New technologies are very useful for certain tasks and absolutely useless for other tasks. We know that an algorithm will be able to diagnose a rare disease that doctors never see or propose a treatment that's very relevant. However, it's not the algorithm that will announce the diagnosis to the patient in a text message or in his email box. We have connected objects that can measure your heart rate, but detecting that you are suffering from tachycardia, the connected object cannot determine that you've just seen your loved one and you're excited for that reason. So new technologies are here to accompany humans, to support people. And technology poses another problem, which is you need to take into account the entire global environment of the patient and not just a precise task. And each patient is unique. Algorithms often work the same way for everyone, and we know that in real life our patients can't be pigeonholed, and each patient is unique. So new technologies are supports for human being. But I say man plus machine is superior to people alone or machines alone. So we as doctors need to adapt to these new tools, and we're not used to working with these new technologies. But we must do so. It will help us treat our patients better. And if some are reluctant, I always say, well, we went to medical school to make sure that our patients would get better, not just for the beauty of the diploma or the prestige after 15 years. So if we have to adapt, we will do so. But these tools must be developed well. They must be really relevant. They must have proven their safety and efficacy. And that's why it takes some time. And that's why people say, well, things haven't changed today. Well, no. In my practice, in pediatric, the emergency ward, my practice hasn't changed much. But I think it is coming. And I think it's for the best.
François François Pelaine with the group Point Vision. You've tried to respond to an issue that's well known, that of waiting times, the waiting time when you take an appointment with an ophthalmologist. You've industrialized things. So the patient's path by focusing the doctor on the care activity. Now, in your organization, haven't you really transformed the doctor into a kind of a Charlie Chaplin in modern times? He comes along, he does a bit of DIY, and doesn't do anything more, really, than his factory work. No, it's quite the opposite. Quite the opposite. First of all, my project is focused on the patient. It's a customer approach. My leitmotif with the doctors in Point Vision is that a happy patient is a happy doctor. So the conventional ophthalmologist, a third of his time is spent on admin, a third on technology, and a third on medicine. Now, is he happy doing administrative work? The answer to that is no. So he doesn't do any admin work with us. There is somebody else who takes over admin. So it's basically a public interest group that is in charge of this. They do everything from taking down appointments to managing the schedule, doing the accounting, etc. So is he happy to be involved in technology? Well, some are and some aren't, but most aren't. At Point Vision, we help them. So you've got a health technician, and you've got an optometrist, and you've got an ophthalmologist. And the optometrist does all of the technical work. So there's no more technical work for the doctor. Now, if he's not doing any more admin or technical work, instead of doing just 30% of medicine, it's 90%. So that's a win-win situation. If it's 90%, that means he sees more patients. The patients are happy because they're seen quicker. And if he sees more patients, well, that means he's got more revenue and everybody's happy. Now, just to finish with Charlie Chaplin, I drew inspiration who's not Charlie Chaplin at all. And I followed the advice of a gentleman called Guy Valencien. And there we go. So Guy has been compared to Charlie Chaplin, but I reckon that's a compliment. So we'll come back to that point next year, maybe. Thomas, you were president of the Union of Pharmacy Interns. You've often tried to bring pharmacists and doctors closer together. So have we got a new mode of exercise? Are we moving towards something that's more interprofessional? And every time we talk about this, and I've talked about it a lot, we say that young people want to be involved in interprofessional activities. But once they're actually set up, don't they just fall back into the old habits and fall into a silo? Well, I think that, yes, there are new modes of exercise, but who, how, where, when, until when? Anyway, coming back to young people, young professionals, I think the main objective is to get them to want to work together. And I think that's already a given. They don't want to work on their own in their own little corner without talking to other colleagues or other professionals in the healthcare sector. We also needed to improve on quality. We've talked about the feedback of patients. We've talked about transparency. And that exercise, well, for young people, it's something that we do at school. So we're in a new dynamic for health, a new dynamic for education. What's going to happen in education? What's going to happen in initial training? I think that we could give people the idea of working around 4 clinics. So in a hospital, a nurse who's at the end of her course, a young student in pharmacy and a young student in medicine. Let's deal with this case. How do you do it? So you create trust. You get them to talk together and to talk about a case using the right language, answering all the questions. So it's all about trust. At uni, I think it's a bit more difficult. One thing is interesting at university. Often there are modules that focus on false patients.
Des comédiens qui viennent jouer.
A bit like comedians who would come and play the role of false patients. So When we do this in a hospital, the older members of the staff see us working in a new way, and hopefully this will help them to adopt this idea too. So what kind of idea can we come up with that's more practical? Well, we were talking about nurses involved in nursing, but why not help orderlies? Why not give them the opportunity to do nursing instead of nurses? Why not give them the possibility for those in the dispensing chemists to go and take the medications out to people and to be involved in observance and monitoring? There are lots of silos that can be pulled down by freeing people up, allowing people to take on competencies at local and regional level with the right business model so that we bring down these silos completely. So bring down the silos. That's also about transferring skills and information. Yes, it's all about delegating tasks because we have the skills, but we can teach those skills. You know, when they're transferred, they mustn't be lost. It's also about having a trust and having trust at patient level. But then locally, everybody does what they have to do. Health insurance, the professionals, knowing who has the right to do what with better diagnosis rather than things based on old conventions and old regulations. Thank you, Thomas. Camille, you're president of the ISNA, which is the Union for GPs. You've probably heard about these things, and you've heard people saying, oh, it was better before. They're not the same. These young people, they're lazy. They don't want to work. They're just thinking about their family life. They don't want to set up in a private practice. What do they want, these future doctors? These new modes of functioning. I'm being provocative here. Is it a need? Does it respond to the need of patients? Or are you just all spoilt children, all these young doctors? Are they spoilt children? Well, I think, first of all, it's important to get rid of some preconceived ideas. Young doctors don't work less, they just work differently. Another preconceived idea, young doctors don't want to set up in a private practice. It's true that young doctors don't want to be in a private practice like they did 40 years ago. They don't want to be in an isolated surgery. It's true that young doctors have different ideas about setting up. They like to work as a group. They think it's better to work in a team as to share skills and also redefine working times. They also are in favor of diversifying functioning modes. So having something that's mixed, having a different consultation method, but also they want to have different careers from a geographic point of view, but also from the point of view of the kind of direction that they head in. So it's not true to say that young doctors no longer want to set up in a private practice. If we look at the last figures of the Association of Doctors, in 2008, 10% of new doctors wanted to set up in a private practice. In 2016, 33% set up in a private practice. So that's fairly significant. Furthermore, the age at which they set up is going down. So to come back to your second question, are we spoilt brats? Of course we're not spoilt brats. We are fighting for a healthcare system that is efficient, that allows us to redistribute financial and human means where the population so requires them. So we have to keep in mind that setting up durably as a healthcare professional in an efficient manner, that is profitable for any given area. It's good for the attractiveness of a local area. It means that we're reducing healthcare costs. And when we can carry out the right kind of prevention, it's also good in terms of efficiency. So investing in young doctors, investing in youth, this is about investing in the health of our citizens. So it's got to be profitable for society. Concerning our aspirations, so talking about the well-being of professionals and the quality of care given and the obvious necessity to optimize healthcare so that we have the right kind of system, these are complementary aspects. The aspirations of young doctors are not disconnected from reality. They are, on the contrary, full part of the healthcare system. So let us set up as we want. It's good for the population. That's what you're saying. Now, Cécile, very quickly, you talked about new technologies. We've talked about startups, innovation. Are doctors trained for this? Are we trained to be enterprising? These new modes of functioning. Is it not about being a doctor and an entrepreneur, dealing with your own day-to-day difficulties in order to set up a startup? You have a kind of a mixed mode of functioning. Can you talk to us about it? Well, I won't surprise anybody when I say that no, doctors are not trained. Once they're set up, once they're overworked and they've got to do admin work, there are some good initiatives in Paris. We've got some different centres, but they're not enough. But the problem is that at the end of the day, the information that gets to the ears of healthcare professionals comes from the media. So what can we say in the media? We can hear that doctors are dinosaurs and they should disappear, that future doctors are basically nurses. And so obviously that's not very motivating if you want to think about the issue. And, we're thinking about professionals as oysters. So, nurses with doctors' diplomas. Anyway, digital technology is part of the roadmap of the minister, the health minister. So hopefully we're going to move in the right direction. But all initiatives helping to train future doctors need to be supported. And for your second question, yes, I think that tomorrow's doctors will be more entrepreneurial, not necessarily doing different careers. We need this because today on the market, there are many e-health solutions that are not adapted to practices. That's because they come from entrepreneurs who are young, who are in good health. They have ideas and they don't get the healthcare professionals involved or the patients involved in their ideas because they can't find any. So basically, there are things on the market out there. I like this example. So there's a connected menstruation cutoff device. Well, basically, it tells them all about their menstruation, the color of their blood, the liters. There's a battery. What's the point of that? And also, potentially, it's a very bad idea. And at the same time, there are professionals, healthcare professionals out there in the field who have real ideas that are relevant. But as they don't have time or they don't have the skills, they try and become businessmen and it doesn't work. They come up with these applications with a design that's not very encouraging and it doesn't work very well. So if the two worlds were to meet, the healthcare professional needs to take part more in the development of such solutions, either by doing two jobs or by testing and assessing these. And for the patient, well, it's the same message. Françoise, turning to another subject. As a doctor, do we not just hold on to our acquisitions, our traditions, and the changing? We were talking about transferring competencies. We were talking about that. But what about ophthalmologists? Should they still be prescribing glasses? Couldn't we delegate that to local doctors or GPs? Or if I dared, maybe address them to my colleagues here. Couldn't we transfer the prescription of spectacles to a non-medical professional? Well, I'm going to be paradoxical. Spectacles are 100% technical, and yet it would be a serious error not to let ophthalmologists prescribe them. This is an error that Gérard Dupourville almost made at the start of 2000. There was a report that came out for the social security system, but as he's intelligent, he knew that it wasn't the best idea. And in fact, he was one of the first to support the Point Vision project that I had. Spectacles, beside the technical side that they have and the optical side, spectacles are carrots. They don't look like carrots, maybe, but they are carrots. Patients come every 2, 3, 5 years to see their ophthalmologist, and what are they allowed to have? A technical inspection of their eyes. This is fundamental, and that's what's important, and that's why it's important that the patient go and see the ophthalmologist, because they may find glaucoma, macular degeneration, a tumor, diabetes, something that hasn't yet been diagnosed, and for which, if they don't go and see the ophthalmologist, this will be to the detriment of the patient. Why not systematize prescriptions then? You know, why not have young doctors do this? Now, there are laws that have been set up by previous governments that have allowed opticians the possibility for a specific period, between 3 and 5 years, for young people, 5 years, to delegate that task to opticians, but on condition that every 5 years there is a checkup, a proper ophthalmological checkup. Screening is important. We know that the minister believes in screening, and it's a good screening model. And it's important to have a technician, but the technician can be in the doctor's surgery. It has to be a technician who works the machinery, and the doctor is there to check up and do the diagnosis. However, I can say that medicine, it's not something that you do in shops. Medicine is what you do in a doctor's surgery. However, why not adopt a different approach? I'm for technological change. Telemedicine is going to allow us to do many things. We can even do tests remotely. There are many things that can be done remotely. But at the same time, the doctor must continue to have that role of appropriate screening. So there are laws already, yes, and they just simply need to be applied. Unfortunately, there are figures around. The possibility for an optician to renew spectacles, as long as there is a prescription that is no older than 5 years. In 100 cases where it's possible, well, out of 100 cases where it might be possible, it's only possible 15% of the time. Now, they're not allowed to advertise about this, but even if many of them applied the laws already, that we would be on a better path. So we've got the change in functioning modes. We've talked about this, and Nicolas Bouzou was saying that pharmacists were going to disappear this morning. And that's making everybody laugh. The pharmacists and pharmacies, they are anchored into our culture. What about the role of pharmacist? Couldn't the pharmacist be more involved in public health? We've talked about the pharmacist as a vaccinating entity. Shouldn't they be more involved or in other healthcare missions as well? Should we be saying long live pharmacists or take them to the guillotine? We have lots of pharmacies in France, and the pharmacy has to have a doctor in pharmacy. So the pharmacist has a lot of training, is very much accessible, and they are in specific areas. So vaccines, prevention, public health, medication, generics, they are in the right place. They are the soldiers. They channel the right prevention messages, the right information. We've encountered many problems with vaccination with respect to professionals themselves. It's something that we don't consider enough for two reasons. The first is that nurses and doctors who don't want them to carry out vaccination because maybe the diagnosis is wrong. The problem with vaccination is that it arrives at a certain time. You know, if the epidemic arrives and it's not the right time, then that doesn't serve any purpose. Somebody said in an article that, you know, you have to have the right coverage, you have to have the right trust on behalf of patients. When you carry out surveys, whether you're talking about the quality of medication or the trust of the population with respect to pharmacists, that's where you see the truth. If they were against a vaccination by dispensing chemists, and it became obligatory, they would go anyway. So there is, you know, a logic behind this dynamic. Now, as you were saying, you know, consultations should be in a surgery, but vaccinations should be in real pharmacies, not in shops. So young pharmacists, do they want to have new skills? Do they want to change jobs? I'm sorry, I forgot to say this. Regularly, I have been invited to conferences of young students in pharmacy. If there's one thing that is sure with them, even when you see the different combats, right up to the president of the Association of Pharmacists, things that they've done to have vaccination. Yes, it's something that is well rooted, and it's really rooted in their genes. So new pharmacists think they're going to be more involved in public health. There's clinical pharmacy, and now that has to be set up in dispensing pharmacies. And then, of course, there's the pharmaceutical aspects that have to be taken into account. So there are a few minutes left. I'm seeing the counter. One last word, Camille. There are changes in these modes of functioning. There are generational changes.
We're going towards a war between the young and the old, because the young generation cannot be reconciled with the older people. No, it's not exactly a war, but we often see that there's an attitude from the older people. They give the impression that they don't want to let us take our place. For example, if we look at sometimes we've even been refused presence during discussions and negotiations. And we wonder why. Are they afraid of assuming their positions with their future colleagues? The models that they've defended for years, or maybe they're not timely anymore. I don't have an answer right now, but they give this impression of defending things that are required for them, but that are no longer valid today. So truly irreconcilable. No, we're not there. There are other examples. If you look at the, but so some old roads. If we look at the Physicians Association, they were envisioning coercion measures for forcing young physicians to be set up without intergenerational solidarity. Another example, a concrete example, would be on the points that can cause problems. If we look at the security report, when the uniforts wanted a security rest, safety rest, the seniors did not accept this well. It was quite a scandal. But now this procedure is a standard. It's considered as a major advance. So that's the negative points. But there, of course, there's still hope. We still come together on some points. For example, on the issue, we work with the seniors, with the young physicians. We work with the Association of Physicians. We're trying to have more exchanges between the generations. On the transversality, to finish on this, we saw that there have been troisième reforms of the third cycle, and young people, the young general practitioners, wanted to have more training in the city, and they wanted to get out of the hospital more. Are we not partitioning too much, having too much of a partition between the hospitals and more in the fieldwork in the city, so there would be more links between the hospital and the city, and to break down some breaks? No, the reform of the third cycle was exactly that. We still have training in the hospitals, of course, but we also have all specialties to work in the hospitals, and also to work in different areas. Just to wrap up, Cécile, as we pursue with these new technologies and the digitalization and artificial intelligence, could the physician's profession disappear? The machines could interpret an X-ray perhaps better than a radiologist. Are we not seeing some of the medical profession disappear? No, not at all. No, the example of radiology is very good, except that, but the radiologists are developing as well, and their field is developing and very useful for the patient. But you have to have a monkey behind the machine. It's not the machine that's the problem. The technology has been here forever, but it evolves quickly too. What's changing is the way that we use the technology and how we are using the technology. So we have to do it so that we can work in synergy, and these new tools are helping us to treat people better, rather than asking if we're going to be replaced, which I don't really think will ever happen. Thank you very much. That was the final word. Thank you very much to our speakers. I hope that you enjoyed this panel. Thank you, Guy. And now